All right, so let's go forward. So I'm talking to you about essential thrombocythemia, and I'm going to be relatively basic. You know, what is the clinical problem in essential thrombocythemia? Why do we worry about this as a disease? And the prevalence, of the normal platelet or the platelet count we start to worry about is a platelet count of about 450. And it's usually not the first platelet count that a patient has, but it's a platelet count that has been elevated over a period of time. And your first primary care that you had might not have cared about it very much, but you got a new primary care who's a second primary care who's been looking at your records and is concerned about the fact that your platelet count has been pretty consistently over 450. In a study of 801 patients with ET, or the hospitalized patients, the prevalence of ET was about 5.2%. And there are many other causes of a high platelet count that have to be eliminated, really, before we think about a diagnosis of ET. So in hospitalized patients and in clinics, we have patients with infections or trauma. A major surgery will cause your platelet count sometime to rise. Cancer of other kinds, iron deficiency anemia. These are all other things that can cause a high platelet count, and they're far more common, actually, than essential thrombocythemia. Extreme thrombocytosis is very rare, where your platelet count is over 1 million. And a third of these patients really had a hematologic malignancy of some kind when they were looked at in a hospitalized setting. But the development of ET is a rare event. There are other things that are far more common that cause a high platelet count. Next. So key clinical points are ET can be associated with an increased risk of thrombosis and bleeding. And most patients have a mutation or a driver mutation in one of 3 genes. A JAK2 in about 60% of patients, CALR in about 20% of patients, and MPL in about 3% of patients. And recognition of these mutations has actually made diagnosis of these diseases somewhat easier, and the fact that we can send peripheral blood looking for these mutations before we go forward and do a bone marrow biopsy. Where in the past it was definitely a bone marrow biopsy was really the first step. But a bone marrow biopsy is needed to make a definitive diagnosis of ET. The risk of thrombosis is associated with other risk factors such as age, so age 60 or greater, or the presence of a mutation, particularly JAK2, and having other cardiovascular risk factors. And patients are classified into 4 categories, really: very low risk, intermediate risk, or high risk, sort of based on those 3 parameters. Low dose aspirin is the main drug used to reduce the risk of thrombosis and is used in all patients except for those potentially with very low risk disease. And cytoreductive therapy is really indicated in high risk patients. It is of uncertain benefit in patients who are lower risk than high risk. First options usually include hydroxyurea or interferon. The CR&T trial, which we'll talk about a little later, demonstrated that ropeg interferon alpha-2b was superior to anagrelide, but we don't really have a great head-to-head trial looking at ropeg versus hydroxyurea. More key clinical points: the median age at diagnosis is age 58. 67% are women. The median platelet count is 876 in a group that were studied at Mayo Clinic. 26% of those patients had leukocytosis, 9% an abnormal karyotype, 21% had a history of thrombosis at the time of diagnosis or before diagnosis, And most patients had other symptoms, and whether they had low-risk type disease or high-risk disease didn't really change the sort of the vehemence of the symptoms. You could have low-risk disease and have symptoms that were really altering to your daily life. Those include headaches, and visual disturbances, dysesthesia, fatigue, pruritus, brain fog. Nearly all patients who come to see me complain of fatigue. After a median follow-up of 10 years, 43% of patients had died. There was leukemic transformation in 4%, the development of myelofibrosis in 13%, and a new second thrombosis in 21%. And overall survival was about 18 years, which was shorter than patients who did not have essential thrombocythemia, who were matched for age and sex. Diagnosis in patients with acquired thrombocytosis. We certainly send off peripheral blood, usually is the first step, looking for one of these driver mutations. And that is in patients who have, symptoms and no sign of other causes which might lead to a high platelet count. So they're not infected. We don't think that they have a solid tumor malignancy. We don't think that they have another hematologic malignancy. We don't think that they have had a trauma. We're looking forward. We don't think they have other issues that might be contributing to a high platelet count. So if we have eliminated those, we can send off peripheral blood looking for a driver mutation. And if they're positive or they have strong symptoms and we still are suspicious that they may have essential thrombocythemia, the next step is really to do a bone marrow biopsy. And a bone marrow biopsy is needed to make a definitive diagnosis of essential thrombocythemia and to differentiate it from myelofibrosis, where the prognosis in the two diseases is very different. So you want to make that distinction, and it will also really impact how you will treat the patient. So it's really important for the bone marrow biopsy to be done to make sure that the diagnosis is correct. Here is a look at peripheral blood smears, which I show because they're really beautiful, and if you haven't looked at them before, you should look at them now. On the far left side there, we show things that are in the differential diagnosis of having a myeloproliferative disease. At the top, you see those really big cells in there. Those are actually something called megakaryocytes, which aren't they beautiful? Which are pre-platelet cells. The ones on the left there, those are in a slide of a patient who has reactive thrombocytosis. So we think they have an infection or they have had surgery, and that's the cause of their high platelet count. Right below it is a myelodysplastic syndrome slide. And this is a slide that is a different hematologic malignancy. And those cells are actually abnormal looking, which you can't tell, but they are kind of beautiful. And I would put them up on a wall if I had a wall that was big enough for it. At the bottom is chronic myeloid leukemia, which is another myeloproliferative disease with which we have a specific therapy for that. In the middle, at the top, that's a picture of essential thrombocythemia. And you can see all of those megakaryocytes, which are those pre-platelets, are kissing each other. And we call that clustering. And that's something that we are looking for when we're trying to make a diagnosis of essential thrombocythemia, looking at patients' slides. And on the right next door to that is pre-fibrotic myelofibrosis, which is the different disease that we need to differentiate. You can see that there's also kissing of the megakaryocytes and clustering, but there's also sort of more abnormalities. The cells look a little funnier with different sort of centers to the cells, which are nuclei. So we look at these very carefully to make a diagnosis and to make the right diagnosis for the patient. I show that just for you to see how beautiful that these pictures are. Next slide. We also are looking now at what kind of mutations that you might have in your cells, and that helps us differentiate between a disease which is more aggressive versus a disease which is less aggressive, and helps us differentiate, if we're sort of on the fence when we look at the pictures between pre-fibrotic myelofibrosis and essential thrombocythemia. And that's looking at mutations in other genes like SRSF2 or U2AF1 or SF3B1 or TP53. All of these genes, will confer maybe a more progressive disease or a more serious diagnosis or a more resistant disease. So we often are looking for these in addition to the driver mutations in JAK2, in CALR and MIPL, to sort of gauge how aggressive we think the disease might be, or when we're on the fence, whether we think it's pre-fibrotic MF instead of essential thrombocythemia. So this is data from the Mayo Clinic, looking at thrombosis and bleeding, and what the rates are basically in patients who are newly diagnosed with this disease. So thrombosis or blood clots can be both in arteries or veins. So they can be in either type of vessel. So those that go away from the heart and those that are returning to the heart. And 14% of patients in the Mayo Clinic cohort of over 1,000 showed arterial thrombosis at the time of diagnosis, and 8% had venous thrombosis. So not high enough to be very concerning, and these can be life-threatening complications. After a median follow-up of 10 years, 15% developed a second arterial thrombosis and 8% a second venous thrombosis. And these numbers were actually correlated with another study, or can be correlated with another study of 891 patients with ET who come from many other cancer centers of excellence. The numbers were basically the same. So they replicated. And other important information from the study is that the conventional risk factors for thrombosis, age, and a history of thrombosis also were borne out by this cohort, and that so were the definitions of very low risk, intermediate, and high risk disease. So it's important that in two data sets, basically this information was well correlated, and that we can pretty safely divide people into risk categories, and that can help us to treat patients more effectively. How is ET treated? Available treatment, it's important to realize that it does not prevent transformation to AML. And no treatment that we have for ET actually prevents the development of myelofibrosis or prolongs overall survival. So we haven't had a disease-modifying therapy that's truly approved and up and running for ET patients. That what we try and do is we try and decrease the risk of thrombosis, and we try and alleviate symptoms. And that's what we're able to do for ET patients. Available treatments, are often used to treat other symptoms of the disease, which are sometimes the reason that we decide to treat patients, including fatigue, headache, tingling and burning, itchiness, rash. The most common complaint I have from ET patients is fatigue. And I wish we had a pill that would actually treat this particular symptom, because it's one that everyone complains of. And it's even with available treatments, we seem not to make significant headway. We end up recommending other things like exercise or even psychiatric type therapies, but nothing really seems to be the absolute cure for fatigue, which is the most common symptom I think patients have. So patients with ET that's morphologically confirmed, which means it looks like it does when we looked at those slides earlier, have life expectancies that are only slightly lower than those without the disease and are generally better than those with other myeloproliferative neoplasms. As I've said before, the objective really is to prevent vascular events and death from a blood clot, and to treat symptoms, and that where our treatment is guided by the risk stratification into very low risk, low, intermediate, and high risk disease. And that therapy can be started just to relieve symptoms as the single goal, which is often the reason that therapy, cytoreductive therapy, is started in patients below the age of 60. We use NCCN and ELN guidelines for risk stratification, and that helps us think about treatment. In very low risk disease, it's usually people who are younger with no prior thrombosis and no JAK2 mutation and at low risk of developing a thrombosis. And these patients, we don't even need to treat patients with aspirin. So aspirin is always a consideration in these patients, but if they don't have a JAK2 mutation and they're very low risk, it's a point of discussion with the patient as to whether aspirin is needed. In low risk disease, again, it's people who are younger, less than the age of 60, no history of prior thrombosis, but the JAK2 mutation is present. In those patients, it is recommended that we give low dose aspirin, but there's no need for cytoreductive therapy in these patients unless there are severe symptoms. And if there are severe symptoms, it's a point of conversation between you and the doctor. If you have intermediate risk disease, you're older, age over 60, but no prior history of thrombosis, and the JAK2 mutation is absent. Again, the management of this disease is usually just low dose aspirin, and that's age becomes the major risk factor. But you also have a discussion about cardiovascular risk and lowering your cardiovascular risk. And low-dose aspirin is the only real therapy that we generally recommend unless there are symptoms that would prompt us to have a conversation about starting cytoreductive therapy. And in high-risk disease, those are patients over 60. They may not have had a prior thrombosis, but the JAK2 mutation is present. And in these patients, low-dose aspirin is indicated. And it's the risk group where we're going to talk about cytoreductive therapy. We usually talk about hydroxyurea versus interferon therapy. And it's a very personal decision. It's a personalized medicine discussion, really, about what other medical conditions that you might have, what other medications you might be on, what your cardiovascular risk factors are, and what your preference is for a pill or an injection, as to what the first drug is that we might start in high-risk disease. There are other things that we discuss at the moment of diagnosis, and they're real lifestyle questions. Please don't smoke. That's one of the most important things that you can do. If you're smoking, you need to stop. Please exercise. The only thing out there that really decreases your cardiovascular risk and prolongs your overall survival. If you look across all studies of everything is being active. So please exercise. And be reasonable about your diet. It doesn't mean that you have to, have no fat in your diet ever, and that you can have no pleasures in your life. You can occasionally, but on a sort of a day-to-day basis, be responsible about your diet. And Mediterranean diet, I'm sure that Dr. Feldman talked about that a little bit, seems to be the favored diet, although the Nordic diet has gotten a lot of press in the New York Times lately, which is really just a different version of the Mediterranean diet. Also, other cardiovascular risk factors that we like to modify are high blood pressure. If you need to be on medication for blood pressure, you should start it. A lot of patients are willing to go on ruxolitinib or on other drugs that they've read about for their essential thrombocythemia, but they're unwilling to go on a medication to control their blood pressure. But if you have a cardiovascular risk factor like high blood pressure, it's really important that you start these medications if that's what you've been advised to do and you've been unable to control your blood pressure with lifestyle changes. Diabetes, if you have it, treat it as tightly as you feasibly can. The GLP-1 agonists, there is a lot of interesting questions about whether or not they are going to be, part of therapy even for myeloproliferative disorders. We don't know yet, but certainly controlling your glucose tightly and following your primary care's recommendations is important. And high cholesterol, we've talked a little bit today about statins. We don't really know, is it the medication type and its effect on inflammation, or is it the lowering of cholesterol? What is it about these drugs which is really the active component? There are many other drugs that are out there now to treat high cholesterol, some of which are injectable also. And it will be very interesting to sort of look at the effects on patients as time goes forward. So it's important to control your cardiovascular risk factors, but also to understand out there in the world of treating myeloproliferative disorders that statins and GLP-1 agonists seem to be things that could be important in controlling disease. And also be cognizant of the fact that people with myeloproliferative diseases have higher risk potentially of developing other cancers. So keeping your cancer screening up to date is really important. So getting your colonoscopy, having your yearly skin exam, particularly on some of the drugs that we give you, having your mammo every single year, and keeping up with your vaccines are very important. I don't know if some of you know that there's actual evidence, for example, for the Shingrix vaccine may decrease your risk of developing dementia. So there are important things that vaccines do other than protect you against infectious disease, which can be important. So eliminate your risk one aspect at a time. So therapy, we try to adapt to your risk. Only very high-risk patients or high-risk patients really require cytoreductive therapy unless you have real symptoms that are interfering with your day-to-day life and your function. If that's the case, then you can discuss starting cytoreductive therapy at an earlier point in your disease. So one size doesn't fit all, that some patients with lower risk disease and serious symptoms may need cytoreductive therapy. And patients who have high risk disease, sometimes we have to convince that they are patients who require cytoreductive therapy because they really feel pretty good. Predicting your risk of blood clots can be done by looking at different aspects. The IPSAT thrombosis score, you can look this up online pretty easily on Google, where you get points for your age, thrombotic events, your cardiovascular risk factors, and whether you're JAK2. And by sort of looking at the number of points you have, whether or not you would really qualify for cytoreductive therapy as an sort of initial conversation with this when you are diagnosed with the disease. Very low risk disease is less than 2 points. So these are patients who really don't need, low risk disease patients are only patients who need aspirin. Very low risk patients, it's a real conversation. Intermediate risk patients also really needed to be treated with low dose aspirin, but it's only those high risk patients which we really need to discuss starting cytoreductive therapy at the time of diagnosis. And again, this is a sort of another slide looking at the clot risk versus your stratification into very low risk or high risk disease. And you can see that in very low risk disease, the clot risk per year is very low, 0.44, per year, as opposed to high risk disease, which can be up to 4.2% per year. So that, aspirin is perfectly fine for the lower risk categories. It's just the higher risk patients who really need to be on cytoreductive therapy, unless you have symptoms which are interfering with your daily life. So just again, to our goal of treatment is to minimize the risk of thrombosis and bleeding. We would like to have therapy that decreases the risk of transformation to myelofibrosis or AML, but we don't really have it at this point in time. We want to decrease symptoms and the effect on quality of life, but we only need to start cytoreductive therapy in lower risk patients if they are having significant effects, symptoms are having significant effects on your quality of life. And even patients with low risk ET, the MOST trial, which was actually sponsored by Insight, patients with very low risk disease actually reported lower qualities of life. In those situations, it really is a situation where cytoreductive therapy should be discussed. But it is not often correlates that your low risk disease has no symptoms. You can have very significant symptoms, just as you can have high risk disease with very little symptoms. So it's always important to have conversations with your doctor about how you're feeling and whether you have symptoms which are interfering with your quality of life, because that's a keystone of real sort of discussion as to whether or not we're going to treat you with cytoreductive therapy. So again, as you can see, very low risk disease, aspirin is a discussion, but low risk, intermediate, and high risk disease, we treat patients with low dose aspirin. NCCN guidelines for high risk patients, we offer hydroxyurea, interferon, or anagrelide. Generally, I offer hydroxyurea and interferon. Most of my patients, if they start anagrelide, have started it at another institution and have basically not felt that they could tolerate the medication. So I use very little anagrelide in my practice. ELN guidelines suggest using hydroxyurea or interferon frontline. A second line treatment, either interferon or anagrelide. And antiplatelet therapy is really the cornerstone of therapy for patients with ET. We use aspirin because it reduces clot risk. And in some retrospective studies, it really has made a difference in patients' symptoms as well. So the real cornerstone of treatment for ET patients is always low dose aspirin. What does aspirin do? Those platelets that are flowing around in your peripheral blood like to stick together. And aspirin is important in interfering in that sort of sticking together and making a blood clot. So that's what aspirin does. Platelets can be a little twitchy in ET, that even if you have platelets that are at 450 or a little bit lower, you still can be at a risk for a blood clot. So that, even if you feel that your platelet count is within a more normal limit, you can still be at risk for a clot, and it's important to be on aspirin. And aspirin blocks platelet activation. Those things that make platelets decide they want to stick together, those things that are part of trauma or a part of infection that make them want to stick together, that's interfered with when you are taking aspirin. Are there exceptions to our giving aspirin to patients? Yes. If a patient has an aspirin allergy or a toxicity like ulcerations, we use alternatives to aspirin, like anticoagulation agents. For CAL-mutated patients in the very low-risk group, we don't necessarily need to use aspirin, and that's a conversation. There's an unclear benefit with a low clotting risk and possible bleeding. So it's really something that we don't necessarily need to treat very low-risk patients with. But you should discuss it if you are very low risk, so you understand your doctor's actual view on it and what other risks you might have. Patients who have acquired von Willebrand syndrome, which is something that can happen when your platelet count is very high, usually over 1 million, and most of the time your hematologist is going to screen you for this if you present with a platelet count that high. Your risk is of bleeding, not of clotting, if you have acquired von Willebrand disease. So it's a reason that we do not give patients aspirin therapy. So when we're thinking about, aspirin, we also are thinking about your other risk factors. There's been discussions about twice-a-day aspirin, aspirin 81 milligrams, aspirin 100 milligrams, aspirin 325 milligrams, even what time of day that you take your aspirin. These are all things that sort of come into play. But when we discuss the doses of aspirin and how it will be used, it's usually considered together with other risk factors, cardiovascular risk factors and other risk factors that you might have for clotting. There was a recent paper that came out looking at patients who've been put on anticoagulation for their heart failure or for some of their cardiac disease, and also were treated with aspirin. And the combination of using the anticoagulation medicine and aspirin in this group looked like there was a higher rate of complications like bleeding and not a lower rate of recurrent heart disease. So there's a lot of conversation that you'll need to have with your doctor if you have heart disease and you have cardiovascular risk factors, and you're on anticoagulation and aspirin together. Hydroxyurea is really the first-line therapy for essential thrombocythemia, and why do we use it? Because clinical trials do show that it reduces the clot risk. There was a study of 114 patients randomized to hydroxyurea versus no myelosuppressive therapy, and there were lower clot rates with hydroxyurea treatment. That's been true looking at hydroxyurea and anagrelide as well. The nice thing about hydroxyurea, it's an oral drug. It's extremely inexpensive, and it's a very reliable medication. But there's no medication that doesn't come without a price. So hydroxyurea works by slowing down the blood cell production. So it can sometimes be difficult to treat your platelet count to a level where we would like it, but not drop your white blood cell count or your red blood cell count. So finding the right dose can be difficult in some patients. Next slide. And there are always risks, potential toxicities like nausea, diarrhea. Sometimes patients get skin or mouth ulcers. And in patients with ulcerations that don't heal, we can't use the drug. These side effects may make it too difficult. You can't take this. Don't take the drug if you're trying to get pregnant. And don't take the drug.
May I have your attention?
Yes?
May I have your attention? May I have your attention? We are conducting a fire drill on the second and third floor. Can all employees respond to staircase B? We are conducting a fire drill on the third floor. We are conducting a fire drill on the third floor. All employees, respond. Staircase B.
I think we just stay here. This happens to us a lot in the hospital too. I mean, I'm sure that the JACO people would be unhappy that we don't run up, but I think we're okay.
It's hard to talk over that.
Yeah, it's really hard to sort of. Well, I'm just going to say quickly, there is an increased risk of skin cancers. So if you're on hydroxyurea, you need to go to your dermatologist for that yearly exam. It's somewhat controversial, but there is evidence for that. And as I said before, we need to titrate the dose to allow your white blood cell and your red blood cell count to be more normal while dropping your platelet count. And that can be difficult and take some more visits potentially for modification. Next slide. There's no evidence that hydroxyurea increases the risk or prevents transformation to myelofibrosis or AML. I generally do not use it in patients who have a TP53 mutation, which is a mutation which confers potentially worse prognosis. And that giving something which interacts with the DNA, which is sort of how hydroxyurea works, is something that we generally don't do in our practice at Cornell. Cutaneous toxicities are probably underestimated in hydroxyurea-treated patients, so that when we give patients hydroxyurea, we may not be asking about them effectively, or you may not be communicating them to us effectively, but there's a study showing that they're underestimated. So it would be an ulceration, which is an open area on your skin. So let's say you bump yourself in the kitchen on a drawer, and you have an open sore there, and that open sore doesn't get better, and you're on hydroxyurea. It's probably the hydroxyurea which is preventing you from healing. And sometimes those can enlarge and become difficult to actually heal. And there are patients that we even have to send sometimes to what we call a wound specialist, who's a person whose whole job it is as a doctor is to figure out how to heal wounds. So it's important, if you're on hydroxyurea, that you monitor your skin, for that kind of problem. You were asking.
Is the lack of healing due to the lower platelets or white blood cell decrease, or is it just the drug itself?
It's probably has something to do with the drug itself, and that's why we stopped the drug. It could be that platelets are actually pretty significantly involved in wound healing. And I wish we understood it better than we do. The wound healing people have some magic tricks that they use, where they use, certain aspects of platelet function to try and heal a wound. So that it could be also the effect on platelets and the things that platelets make to help them help you heal wounds. So not entirely clear, but what is clear is if we stop hydroxyurea, that you can heal the wounds. You can also get wounds inside of your mouth, which are sores inside of your mouth. And those can also not heal well when you're on hydroxyurea. So if that happens, it's something to talk about with your doctor or even your dentist, because healing of those wounds, may require the intervention of your dentist as well. Next slide. So interferon is the other drug that we use, and now the drug preparation is generally Bezremi. It can induce a molecular response in some patients with JAK2 or CAL mutated ET. These studies are actually looking at a different interferon than Bezremi, but it's interferon-based data. Interferon may be better than hydroxyurea for patients with PV, and we know that from the PROUD PV study, which I'm sure has been mentioned today earlier. There are very high response rates to interferon with a low clotting risk when used in ET. And it's safe to use while trying to get pregnant. And there are no known effects on fertility. Now, Bezremi has not been studied, as I think Dr. Hobbs discussed, as a interferon preparation in the process of becoming pregnant, and on its exact relationship to fertility. So we don't.
First trimester of pregnancy.
Yeah, we don't know anything about the first trimester. So, we don't have, final information on Bezremi, which is really the preparation, which is out there and which insurance is going to approve for people. So we need a lot more data, and, hopefully we will work together and get some of this data so we can recommend it more safely. There are other preparations of interferon where there has been more experience in using them in pregnancy. There's still, some of those are still available, but not clear, for how long. It does not increase the risk of skin cancers, which is the other important thing about interferon. So a patient who has a lot of skin cancers and we're deciding between hydroxyurea and interferon, that comes to play as which drug we might want to use. Next. What does interferon do? That's a really good question. It certainly does a lot, and we know that it specifically disrupts the MPN stem cell, but exactly how it does it, we don't have great scientific explanations. But we definitely know that it probably has something to do with its effect on the bone marrow environment as well as the stem cell. And SURPASS ET trial recently completed of 245 patients with resistance or intolerance to hydroxyurea that were assigned to Ropeg interferon versus anagrelide with a median follow-up just over a year, where Ropeg actually looks like it's a very effective second-line treatment for patients with essential thrombocythemia who have not responded or have intolerance to hydroxyurea. And that's in comparison to anagrelide. This has become now, I think, the major second-line player. If you're not a first-line user of interferon, it's really indicated, I think, in the second-line setting for patients with high-risk disease. Next. Are there risks? Yes, there are. Interferon has been associated with the development of flu-like syndrome. When patients look it up on the internet, interferon was used most broadly for hepatitis. And when you're looking at side effects of interferon, what side effects are there to interferon? You put in Google, you're going to get a lot about the flu-like syndrome and how terrible people felt on this drug. But be careful, because much of that information has to do with hepatitis C treatment. And they were treated with an antiviral medication as well as interferon, so 2 medications. And the press on interferon is awful if you look at that, but that's not the way that we use it in myeloproliferative diseases. It's a much lower dose, and it's as a single agent. And it's generally better tolerated with less of a flu-like syndrome reported. You can't take the drug if you have an autoimmune disease like rheumatoid arthritis or lupus. So there is a small risk that an autoimmune disease, if you're brewing it already, will sort of come to the surface when you're on interferon, and that can be a side effect of the drug. But if you already have an autoimmune disease, it's a contraindication to starting the drug. It can cause mood disorders, mainly depression and anxiety. If you've been on a medication for depression in the past and you've stopped it, you might have to go back on the drug. We monitor you carefully for signs of depression and anxiety, and if you have it, we have a low threshold for starting you on a medication or sending you to a therapist for evaluation. Again, we need to titrate the dose to avoid low blood counts. That sometimes on interferon, we can drop your white blood cell count or your red blood cell count in addition to your platelet count, and that may cause us to adjust the dose. When you first start the medication, we may need to see you more often, just so that we get the dose to be the correct dose for you, and that we can send you sailing out there feeling, not becoming neutropenic, which means not having enough cells to fight infection, or becoming anemic. Interferon discontinuation rates are about the same as hydroxyurea. So when you read the bad press about hepatitis treatment and the very high discontinuation rates, they were not so high. They're not so high for MPNs. Anagrelide, as I said earlier, I don't use much anagrelide. That patients usually come to me on anagrelide and they've not been able to tolerate the drug. As a second-line agent, generally interferon would be my preferred agent. So anagrelide would be really a third-line agent that I would use in patients. I don't think that it's going to be for anyone after the SURPASS-ET trial their first choice as a second line. There are a lot of side effects to anagrelide treatment, which is why people come to me on anagrelide and are asking me if there's anything else that's out there for them. Next slide, okay. So anagrelide does selectively decrease the platelet count, just as the other drugs we have been talking about do, but it has more side effects. Next slide, I think. Including nausea, diarrhea, cardiovascular side effects, anemia, kidney problems, and those are more serious side effects than some of the other medications that we use. So in general, as I said before, I don't use much of this medication. Next slide. The risk of developing leukemia is actually relatively rare in essential thrombocythemia, 0.7% at 10 years in one study, to 0.1% at 15 years. The Mayo Clinic data a little higher at 4% at 10 years, but the risk of transformation is low. However, we can't really identify the patients who are going to transform. We can become concerned when we see some of those mutational studies that I talked about earlier that are positive, that you have a more aggressive disease and that becomes more possible. But we don't have a way of identifying who the patient is that's going to develop AML. And we don't have a therapy that's going to prevent the development of AML that's FDA approved at this time. That's also true of myelofibrosis, which is rare, 3.8% at 10 years. but much higher at 20, 19.9%. And if you have the disease for 30 years, almost 30%. This study was a Mayo Clinic study. Median time of follow-up was 12.4 years. But the risk of myelofibrosis is higher. But again, we can't identify necessarily who the patients are who are going to develop myelofibrosis. We look at those other mutations and we, again, worry about the risk of progression. But we don't have a drug at this point in time that's going to definitely prevent you from developing myelofibrosis. And again, that's the drug we're looking for to treat ET patients. Hope is on the horizon, and to talk about the drugs that I'm excited about now, the CALR targeted therapy and better JAK2 directed therapy are definitely things that are in the hopper for ET patients. And looking at the multi-CALR targeted therapy, which is from Insight, patients had a great response rate, and there was peripheral blood allele frequency decrease was observed in a lot of patients. So this is really an exciting potential development for CALR treated or CALR positive patients. The new JAK2 inhibitors, that's another possibility for patients. But as we mentioned in the sort of discussion at the end, it's a long time before these drugs are going to come to the marketplace per se, particularly in our current environment. Things are going to move a little more slowly. So the drugs which are out there now, the LSD1 inhibitor, which is from Merck, which is out there on clinical trial, those are things that are more readily available and more likely to come to the clinic faster, so that if you have access to enrollment on a clinical trial that could be disease modifying, it's worth it to think about, because none of the drugs we have are going to prevent, are going to increase your overall survival or are going to prevent transformation to myelofibrosis or acute leukemia. So we're still searching for the Holy Grail. It might be here. I'm hoping, but that is still a few years off from being available to patients. So talk with your doctor about available clinical trials. Next slide. This is just a few slides looking at Cornell patients, our own group, which again is in the appropriate, it is in line with all other studies looking at the female to male ratio. We have really generally patients with very low risk or low risk disease at Cornell. For that reason, many patients were not on initial cytoreductive therapy, but they were on a combination really of all available therapies. And the median platelet count at our institution for starting treatment of any kind was a platelet count around 766. The clotting risk is higher in our patients who are with JAK mutated ET as expected, but progression risk was higher in our CALR mutated patients, also which would be expected. Next slide. So our very low risk ET patients had an outstanding overall survival, as you would expect. And our myelofibrosis patients are patients who had very low risk ET but were CALR positive, had a worse overall survival, mainly because they transformed to myelofibrosis. Next slide. This is just a summary slide of the therapeutic options for ET patients, which we've gone through before. hydroxyurea and interferon versus second-line therapy, which would be interferon, Bezremi, anagrelide, ruxolitinib. In certain older patients, we have used busulfan in our clinical data set, but we really don't use that anymore. And most patients are on aspirin for their ET, a few patients on anticoagulation. We have very few patients in our roster who are on both anticoagulation medications and aspirin at the same time. Next. Thank you for your attention.